again to the live streaming sessions, live interview sessions here for the third and final day of this 22nd Bangkok International Symposium on HIV medicine, whereby we find out the latest advances in HIV treatment and beyond as well. And for this session, we will be focusing on several interesting topics: HIV therapy in an era of polypharmacy. We are also going to be given an update on STI management and healthy aging for people living with HIV. Now, usually how we do it is that the doctors, the experts go inside the plenary room and deliver their presentations, and then we bring them out over here to sort of give us a wrap-up of the highlights and the main takeaways that they delivered inside the plenary hall. But now we're doing it different. There's been a switch here. We're going to have them here exclusively, have them here first for them to give us an overview before they go back inside to deliver their full presentation. And co-hosting this session with me, we have Dr. Peter Rice from the Department of Global Health, Academic Medical Center, Amsterdam Institute of Global Health and Development, traveling here from the Netherlands. Sawadee ka. Thank you very much for coming back. You were here, how many years has it been now consecutively?
Many years.
Many years.
It's wonderful to be back.
And it's great to have you. Your expertise is really much appreciated here. We'll start then with the first topic, which is on HIV therapy in an era of polypharmacy. Dr. Tim Cressey joins us from the Program for HIV Prevention and Treatment. Sawadee ka. Welcome, Dr. Cressey. Good to have you here. You didn't travel too far, just from Chiang Mai.
Yes.
Great to have you here in Bangkok.
Good to see you again, Tim.
Thank you, Peter.
Very well. So you'll be speaking on polypharmacy, and maybe it's a good thing to start off with a question on what is polypharmacy in your view?
Yes, as you said, I think the focus of my presentation is polypharmacy in the era of HIV therapy. And as you said, the first question is, what is polypharmacy? And I think in its basic terms, it means just many drugs.
Okay.
So, but in the medical literature, it's basically coming down to if an individual is taking 5 or more different medications. Now that doesn't necessarily mean 5 different tablets. It's actually the medications themselves. So it could be many more tablets than that. So in an HIV world, as we've seen at the meeting over the last few days, the medications are excellent now, coming from regimens to 2 or 3 drugs, but often now in one formulation.
Right.
So, but then when people living with HIV are on antiretroviral therapy, during their life, they're going to be taking other medications at different stages of their life. So adding these drugs on top of the antiretrovirals is where the polypharmacy issues arise.
Right. And then why is that important? Why does it need to be studied? What does it mean for the patient? What problems would it be able to cause?
Yeah, so the problem with polypharmacy can be, and as I mentioned, it can occur in an individual who is HIV infected. They may have issues when they're first infected. Maybe they have other concomitant diseases, such as tuberculosis. Right. So at this stage of their treatment, they may require tuberculosis treatment and antiretroviral treatment. And adding these 2 drugs and treatments together can then, depending on the interaction between the drugs, can either increase the efficacy of one drug or decrease the efficacy of another. And it's a little bit of a drug dependent. So, but on the opposite side of the coin, it could be that the drug concentrations perhaps go too high and toxic. So it's a balance of getting, adding these drugs together does not necessarily go together nicely, and they have to be adjusted accordingly.
Right. So it's important to get that right, and it's important for clinicians to know about this. But at the same time, I could imagine that as a clinician, there's multitudes of drugs. It's difficult to keep track of what interactions and how. So how can you assist clinicians in dealing with that?
So I agree that, there's only so much information you can keep in your brain.
Right.
You cannot remember every drug-drug interaction.
Right.
So during a drug development process, during that period of time, they do often do common drug-drug interactions with drugs that are commonly used in the everyday clinic with antiretroviral drugs. So we know some of the interactions. But of course, they don't do every single interaction study possible. So it's impossible to know in some cases when you say, I need to prescribe this drug, what will happen. And there are online databases and applications now for mobile phones where you can plug in different drug combinations, and they may give you some indication of what to expect, whether there's zero chance of an interaction or perhaps a medium to high chance of an interaction. So then you have to be able to judge as a clinician, is this the best drug to give given the background antiretroviral treatment?
Correct. At least from my personal experience, those apps and those tools are really very helpful. And I think you just said it. Nobody can keep it all in their minds, and it's important that people know those tools are available and actually easily available, and remember to look at them. Yeah.
And during my presentation, I work at the University of Liverpool and have links to it, and they have this very good website called HIVdruginteractions.org. And on a few of the slides, what they've done over the last few years is looked at, of the people who are searching on their database, which are the most common searches to do, which are the drugs they're looking at, and this perhaps maybe more Europe biased, but they're looking at, you know, the statins used for cholesterol. As people age, they take more medications for specific, you know, elderly related illnesses. So these are the common interactions that people are looking for in the future.
Definitely, and they are also the ones that have created the app, which is very easily downloadable, and I personally couldn't do without it. So, no, that's wonderful. So, in your talk, apart from the general issues that you'll be discussing, are there any specific key elements that you for the region that you will bring out?
I think one of the issues that, like I said, often the drug-drug interactions are more focused around, you know, core diseases or core illnesses, but often there's people wants to take things for health in the, let's say, the mid-adulthood, like, you know, vitamins, maybe they have some antacids, but also for females taking contraception. So females may want to take, you know, contraception living with HIV, and there's a lot of studies now where, you know, looking at implants to see how that impacts the drug concentrations that the women are on, and are they at a higher risk of pregnancy. So there's certain contraceptive agents which now we know perhaps should not be given with certain drugs, and they may have to use a different contraception.
And thinking of I mean, continuing that theme, I mean, here in the region, thinking of certain key populations like men having sex with men, or transgender women with hormone replacement therapies and stuff, chemsex, I would assume that again is an area which, for someone like yourself, investigating drug interactions is a very relevant one.
Yeah, over the last few years, the chemsex studies, which are very difficult to do in terms of doing a study and looking at chemsex. But people's experience who are seeing individuals who are having issues with their drugs, and then they're asking them, are you taking certain drugs for you know, in nightclubs, and then they find out, well, maybe this is, and this is more, rather than formal studies, and more case reports. I think this is the best way to get that kind of data. But it can be also very serious. People can have really strong, you know, almost life-threatening interactions, which, because of the adding these, you know, unknown medications which they're buying off the streets to an antiretroviral treatment.
Right.
Thank you so much. We definitely look forward to your full presentation later on after lunch. Once again, thank you for being here, Dr. Tim Cressey, at the Program for HIV Prevention and Treatment here in Thailand. Next, we move on now to STI management. Dr. Donn Colby, who was here yesterday, joins us once again, Senior Clinical Research Physician at SEARCH of the Thai Red Cross AIDS Research Centre. Sawadika. Welcome back, Dr. Donn. You have much more information to share.
I hope so.
A preview here before you take the stage in there.
Yeah, so welcome Donn. Nice to see you again. STIs, obviously something very relevant, I would say globally, but certainly also here in the region. And lots of ground to cover, I could imagine, in the talk. So what in your mind are like the three main, or some of the key important things that you want to address in your talk, or that you'll be addressing?
Yeah, so one in the talk we'll put a little bit about epidemiology, and that's right. I mean, you said the rates are increasing everywhere.
And how is that situation here in this part of the world?
Actually, in Thailand, it's pretty good. I mean, there's high-level resistance to ciprofloxacin, or the fluoroquinolone. quinolones, which we pretty much see everywhere.
Right.
But they have not identified any cases of ceftriaxone resistance or cefixime resistance. Is though.
PrEP for HIV.
Right, right.
And people saying that STI rates may increase. So is that something that will come up in your talk or not specifically?
Actually, not today, but we did talk about that in my talk on Wednesday about PrEP.
Right.
Because in that one we were talking kind of the sort of, we call the perils of PrEP, or sort of the negative side of PrEP, and STI rates, increased STI rates was part of that.
Right.
And I think it's a little bit of a controversial topic.
Yeah.
You know, people say it's real. It really does have increased rates for people who take PrEP. Other people maybe don't believe the data, because to really say that, you need good data, like before you take PrEP, to have STI testing done regularly, and then after you take PrEP.
Right.
And in most places, because when people are on PrEP, they have to come back every 3 months, and in developed countries, they'll do STI testing on a frequent basis.
So it actually creates an opportunity.
Right. Whereas if people are not on PrEP, so particularly HIV, people don't have HIV and they're not on PrEP, they have no reason to be coming every 3 or 6 months.
Exactly.
So they're just not getting tested as often.
Right.
So it's you know, is it there actually is more STIs, or are we just looking more, so we find more in people in PrEP? But there is a few studies mainly from high-income countries and mainly with MSM, where they did actually follow people before PrEP and after PrEP.
Right.
And the data, actually, I believe the data that there is a sort of a mild to moderate increase in STI rates after starting PrEP.
Right, but I mean, I guess also I know I've been slightly involved with some of those studies in Amsterdam, but the follow-up is relatively short still. So you can't rule out that with longer-term follow-up, actually, you may see an improvement.
Right, and actually the WHO looks at this as an opportunity.
Yeah.
Not necessarily a risk, but an opportunity, because we're going to bring people into the clinics more regularly. It's an opportunity to do testing, and then hopefully when people do have STIs, catch it earlier, treat it earlier, and then in some modeling scenarios, PrEP actually results in a lower rate of STIs in the community, because of the increased testing and earlier treatment.
Exactly. What about, because that's something that got attention, I think it was last year, the study from France where they tried doxycycline as a prevention of STIs, also in the context of PrEP.
Yeah.
Is that, what are your thoughts on that?
Yeah, so it's interesting. So that was part of the IPERGAY study, which was the on-demand PrEP. And they also added a element of STI. It wasn't PrEP because it was after, it was PEP, using doxycycline, one dose after sexual activity. And it did show a decrease in overall STIs, but specifically in syphilis and chlamydia, which can be treated by doxycycline. So gonorrhea, which is, most of it is resistant to doxycycline, did not show any difference at all. But if you look at all STIs together, there was actually a decrease in that. So of course people are always reluctant to just give out antibiotics freely like that, because of the risk for resistance, not only of the STIs that we're worried about, but for other bacteria that are in the body. So there doesn't really seem to be a consensus yet whether it's good to do it or bad to do it.
No, but I think it's a single study, but it sounds like you do think it's an area that merits further research.
Definitely. Yeah, definitely, since we're seeing such high rates of STIs and they seem to be going in the wrong direction still. We need to think about what are new or different things we can do to try to bring those rates down.
Right. And what about novel? Are there any novel STIs that are emerging that need our attention?
Yeah, there's a few that I talk about in the lecture today.
Okay.
So one is a STI called Mycoplasma genitalium. And it's actually a relatively new bacteria that was just discovered in the 1980s. And there was also some debate at the time whether is it really an STI, or is it just sort of a normal flora organism? But I think the data now looks pretty good that it does cause symptoms.
Okay.
Although like chlamydia and other STIs, most people have it actually asymptomatic. But it can cause symptoms. So in males, it can cause urethritis. And in females, it can cause cervicitis or PID.
Okay.
And there is tests. We can do tests for it now, PCR-based tests, similar to what we have for gonorrhea and chlamydia. And it's treatable with antibiotics and curable.
But probably costly still, the tests are not
of
widely
course,
available
everywhere.
Tests, okay. So a new area to follow.
Right.
Okay.
Right.
Do we have,
yes, please. No, we
okay,
do.
If we have,
Please.
I was going to say, and then there's other diseases that really are sexually transmitted, but we don't necessarily think of them as sexually transmitted diseases.
Okay.
So examples of that are like hepatitis A, hepatitis B we know, and hepatitis C. And we've actually seen outbreaks of hepatitis A and C in our HIV positive populations in Thailand within the last few years, which is very clearly sexually transmitted.
Right, so that sounds like similar what issues like we've seen in my own part of the world, which are clearly important. And of course with hepatitis C, you now have a treatable condition, and my understanding is the price of drugs is decreasing in the region, so it becomes affordable. But again, it all starts with diagnostics and detecting. Okay, well, that's very interesting. Is there anything else like top take-home messages from your talk that you want to share with the audience?
One of the things we didn't mention so far, but I think is important, is HPV vaccination. Actually, obviously, HPV, human papillomavirus, is a sexually transmitted disease. There's a vaccine, a very effective vaccine for it. And it's spotty whether it's recommended in the national programs for vaccination in Asia. But even in the places where it's recommended, the implementation so far has not been very good. So that's something I think that we have a ready vaccine for it. Most ministries of health are recommending it, but we really need to get it out to the people who need it. So that's
the
something I think
implementation side is essential, and especially since from this particular region or the Asia Pacific region has shown that it actually works. And it's preventing cancer is clearly a big plus. Okay, well, thank you very much and for being with us.
Okay,
Thank you, Dr. Donn Colby. We definitely look forward to the full talk, the full update on STI management, which is happening today at 2 p.m.
Okay,
so
thank you.
Stay around as he'll share with you all the latest updates regarding STI management. And now for the last topic for this final live interview session, we will be focusing on healthy aging. So ladies and gentlemen, I'd like to now invite to our set here Dr. Reena Rajasuriar, Senior Lecturer at the Department of Pharmacy, University of Malaya in Malaysia. Sawadee ka.
Thank you.
A warm welcome.
Thank you.
Hi. So we're talking about a topic which is close to my heart, as you know, in my research. So why is nowadays aging always on the agenda at any conference? What's the need?
Well, I think we can credit that to the really good antiretroviral therapies that we've had. And I think now it's 37 years since the start of the epidemic. And since the introduction of antiretroviral therapy, that has really extended the lifespan of people living with HIV. At one time, the disease used to be seen as a death sentence, but now it's a chronic manageable disease, which means everybody is living to near normal life expectancies, and you're growing old. And so the pattern of the demographics of people living with HIV is changing. There are more and more people living to ages above 50 years old, 60 years, 65 years old, which is the official cutoff age for elderly in terms of chronological age. And so we are having more and more people living to these age categories, and individuals are developing age-associated diseases which we never saw before, and now we're seeing more and more of.
Right. So is that different from people without HIV? Because unfortunately we're all, as we get old, and I'm speaking for myself clearly here, we're at risk. Is that to a large extent the same in people with HIV or
what
different?
We're seeing is that many of these conditions, the onset of conditions are occurring much earlier. And whether this is because the process of aging is occurring faster, or because you have a much higher risk factor, lifestyle risk factor that's causing these conditions. And this is still sort of debatable within the field. But what we're seeing is many age-related comorbidities, frailty occurring at a much younger age in patients. And that poses some problems. One is that means that screening for many of these conditions need to happen much earlier, potentially. And a lot of the times for our patients, they come to the infectious disease or the HIV doctor is the only doctor that they see.
Right.
Which means the HIV doctors now need to also start managing a lot of these diseases or these comorbidities, which otherwise usually are managed by primary care doctors, which means your expertise and your time and your consultation and all of these will change over time. And
right, but at the same time, you may not actually get the time during your office hours to do that.
To do all of that.
So I think people, clinicians, are struggling everywhere across the world, right, on how to best deal with this.
Manage these conditions.
And there may not be one best single model. I guess it depends on how your healthcare is set up.
Exactly. I think how we manage this whole interface of aging and HIV is going to be very contextual.
Yeah.
It's going to be very dependent on what your healthcare system looks like, how much of expertise you have within your clinic. And I think in the low middle income countries, this is going to be moving towards perhaps task shifting, getting some of the screening and early management to be done by trained nurses or paramedics, so that doctors can be left to deal with the more serious conditions, because we're never going to have the resources or the health support, the HR support that other developed countries have. But we still have to deal with the problems. We can't just let it be.
And do you think HIV actually, in a way, can serve as a model? I mean, we're living in a world where nowadays universal health coverage is the new buzzword, which is easier said than done, I think.
Yes.
But to what extent is what you'll be talking on and what you're involved with maybe able to actually make that happen? Initially in the context of HIV, but hopefully wider than that?
I think I'd like to hope that it will, because HIV then can be the focal point of where patients come to, but then you then bring in other expertise in order to do collaborative practice. And I think it will take a lot of communication, coordination, but I don't think that it's impossible. I think if everybody has the patient's best interest at heart, you will be able to achieve collaborative care that way.
Yeah, so it really must come from the approach of patient-centered medicine. And,
exactly.
And it's interesting how in where we are now and at the Thai Red Cross AIDS Research Center, they've taken that on.
Yes.
Not so much from the side of aging, but providing services to transgender people,
exactly.
Adolescents, and maybe that model can be expanded into the issues that you're talking about.
That's true. And I think a lot of what the Thai Red Cross has done is also listen to the needs of the community.
Exactly.
And that's something I think not many people have done in the realm of research in HIV and aging. A lot of the time it's come from a very clinical researcher perspective. But we've not really taken the time to ask the community what is it that is of concern to them and what they would like us to work on. And that was some of the things that I'll be touching on in my presentation later.
Okay. In your presentation, we haven't touched on research in the area of HIV and aging. Is that something that you'll bring up in your talk? And are there like main areas that, in your opinion, need attention?
So one of the things that I've been trying to introduce is the concept of functional aging rather than chronological age, because we always define aging by your birthday or your age, 50, 60. But people can have different capacities.
Right.
At an age of 50, there are some people who are still very fit and can run marathons, and some people who just can't do simple things like walk up
And
the stairs.
that's true for people with HIV on treatment as well.
Exactly.
Yeah.
And so I think assessing the needs of patients and working through intervention shouldn't really be based on your chronological age, and which means that we need newer ways of trying to detect when patients start losing their function and their capacity. And that might need further training for ID clinicians or how we manage the patients. But it's really looking at a whole new concept of how we manage these patients in terms of aging, not really just by age, but really how they deal with their day-to-day lives.
Right, but also at the same time maybe develop predictive markers of who is going to not do well and who's going to do well, and then how can we intervene.
Exactly, and that will need quite a bit of collaborative research within different countries, because what we've been trying to do is borrow lots of tools from the non-HIV population and try to fit that within what we've been doing with patients with HIV.
Yes.
But the process of aging might be different, and what drives aging might be different. And for us to validate these tools again, we'll need large cohorts in order to do that.
Right. And it might be different, but it might also be the same.
Exactly.
So I think what I've learned is to really keep a very open mind in this complex field. But yeah, and again, I mean, if we would be able to accomplish what you're saying in the context of aging, that could have major spillover for the general population and an aging global population. Right. Any additional, without giving everything away, anything additional from your talk that you want to specifically stress
No, just
here?
tune in.
Great.
Tune in, and I'm sure they will appreciate you so much giving us an overview of what you will be covering in your talk later on healthy aging among people living with HIV. Thank you very much.
Thank you.
Khop Khun Ka to you.
Thank you.
Dr. Reena Rajasuriar, Senior Lecturer at the Department of Pharmacy at the University of Malaya in Malaysia. And I must thank you so much to you as well, Dr. Peter Rice from the Department of Global Health, Academic Medical Center and Amsterdam Institute of Global Health and Development, joining us from the Netherlands. Thank you
You're
so
very welcome.
much. Thank you.
Thank you.
And that is going to wrap up the final live interview sessions as part of the 22nd Bangkok International Symposium on HIV medicine. Continue to tune in, as we do have a lot more coming your way, many more experts and doctors sharing with you the latest advancements. But we will be back with you again next year for the 23rd Bangkok International Symposium on HIV medicine. My name is Pachari Raksawong. Sawadee ka.